Hello and welcome to the Retina Radar podcast. I'm Arshad Kanani, Managing Partner and Director of Clinical Research and Director of Fellowship at Sierra Eye Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. In each episode, I'll be sharing information on the latest breakthroughs, clinical insights, and practical pearls for your everyday use. We'll hear from leading experts, explore cutting-edge research, and discuss the trends shaping our field. Whether you're in clinic, in surgery, or on the move, Retina Radar keeps you informed, inspired, and ahead of the curve. To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Before we begin, please review the faculty disclosures and learning objectives. If you have a question for our experts, send it to us at cme@vindigocme.com, and it may be featured in a future episode. This podcast is supported by an educational grant from 4D Molecular Therapeutics, AbbVie, Adverum Biotechnologies, Alkeus Pharmaceuticals, Astellas, EyePoint Pharmaceuticals, Genentech, a member of the Roche Group, Neurotech Pharmaceuticals, Ocular Therapeutix, Oculis, Regeneron Pharmaceuticals, and REGENXBIO. Today I'm joined by my friend and colleague, Dr. Patricio Schlottmann from Argentina, Head of Ophthalmic Research at the Charles Research Center in Buenos Aires, Argentina. Welcome, Patricio.
Thank you, Arshad. Pleasure to be here.
We just finished a very successful CTS 2025, and thanks to you for being a program committee member. The meeting was very successful, in addition to all the other program committee members and meeting co-chairs with me, Dr. Jeff Heyer and Peter Kaiser. So Patricia, today we'll be discussing the latest data on ongoing clinical trials and things we covered at Clinical Trials at the Summit 2025. And nobody better than you to be here because you're so deeply involved in clinical trials at a global level in terms of designing and executing trials. But before we dive into all the fun data, we want to know who Patricio Schlottmann is. So first we start talking about how you ended up doing what you do, being a retina specialist.
Basically, I finished my basic residency in ophthalmology in Buenos Aires, Argentina. When I finished my training, I perceived that I needed something else. It was the time, this was year 2000. So it was the time of the beginning of the OCT. We would see images that we have never seen before. For the young doctors these days, that's a given. You know, they enter the practice with this technology. Then I moved to London, where I did my research fellowship, mostly related to imaging. So I did some glaucoma work, retina work, neuro-ophthalmology work as well, always using OCT to look at the different imaging devices, did some clinic there as well work. I got my medical license there, so it was a great time for me. I spent 6 years in London, and when I went back to Argentina, it was the boom time of the clinical trials in Argentina. So I started doing the View 2 study, where we tested aflibercept versus ranibizumab, and then we did the Ride and Rise, which is the study that led to the approval of ranibizumab for treatment of DME. So that was my kickstart. I never left clinical trials and medical retina since then.
Great. So was there somebody who inspired you to be an ophthalmologist?
I actually was inspired to be a doctor by a friend of the family. He was a plastic surgeon, but then when I was, getting myself into surgery, I said, no, I liked better ophthalmology. I like the idea of technology, happy patients most of the time, getting into little things. So I liked ophthalmology from the very beginning, and I left surgery or plastic surgery away.
And are you medical and surgical retina?
I'm only medical retina, but mostly focused on research these days. I see very, very few patients that, just come for regular clinic visits.
Great, great. I know you're from Argentina. You're probably a soccer player and a big Messi fan, but tell me, what is your favorite hobby?
My favorite hobby is, I would say, sailing, but
Oh, wow.
I don't have the time to sail that much. So my favorite hobby is traveling with the family. A couple of years ago, we managed to do the two things at the same time. So putting the family within a boat and traveling around the Caribbean. So that was great. Having the family together and enjoying sailing, which is my ideal scenario. I would hope to retire into that sort of life, boat life and with the family around, of course.
Oh, that's great. Sailing, I would have not expected that. You're very like high energy and always on the go. Sailing is more like relaxing, and that's great.
You have to do a lot of work.
But it is a lot of skills for sure. Okay, all right. So let's dive into some of the presentations we had at CTS. We can't cover all 89 or whatever talks we had.
It was a long, fantastic meeting.
Yeah, but we can cover some of like innovations that are coming out from this meeting that we are really, really excited about. And we haven't seen this much novel, treatment options coming out for a long time. You and I have been doing this for a while, and this is really very exciting time in retina and very exciting time for patients because we have a lot of early, mid, and late stage developments that are happening in the field, and that can really make a huge impact on patients in terms of treatment burden, in terms of their outcomes, in terms of preserving long-term vision. So let's talk about early stage stuff first, and then we're gonna move into some of the later stage stuff. So some of the presentations that were given at CTS 2025, we wanna cover a few of them. So let's start with Olin 324, which is a bispecific antibody. You can tell us a little bit about what that drug is and what stage of development it is in, and what are they going forward with?
Let me take on something that you just mentioned, which is we have so many new treatments in early stage. We have so many things going on. One would assume that there was nothing left to do, and there were so new mechanism of actions. OLN 324 is a bispecific, much smaller molecule that is anti-VEGF and anti-Ang2, but being a small molecule, it's capable of putting a big molar mass inside the eye. So we can have a massive effect of these things that we know already work from, for example, faricimab. So we know that blocking VEGF and then blocking the Ang2, allowing the Tie2 receptor to, get back rolling. It's a good treatment option. This is data presented by Margaret Chang. It was absolutely fantastic to see the results, and we hope to see this drug moving forward to a later stage.
I think, it's very exciting, right? How can we do better than faricimab, which is an amazing drug that you and I have been involved with since the early days, and we have seen the real world data in terms of disease control and durability. And then the next one is ANXV, disease modifying agent for RVO. It's a very different paradigm. It's an IV drug for retinal vein occlusion, and it has some really solid science behind it. So tell us a little bit about that molecule and some of the data and what's going to happen.
So the data was presented by Michael Singer. He's behind the development of the drug, of course, as well. This is annexin 5, so ANXV comes really as a good reminder of the name of the molecule. And basically what it does is the true treatment for RVO. These days we think that we treat RVOs by using anti-VEGF, and that's not the case. All we're doing is getting the fluid away of the macula, so the RVO resolves on its own. This use of annexin 5, which is basically the molecule that you get through an infusion intravenously, it's basically dissolving the clots and resolving the RVO itself. So why wouldn't we avoid the whole process of having the RVO, having the ischemia, then we have VEGF, then we block VEGF because it produces edema. Maybe we just resolve the clot on its own. That's going to be a very, very important treatment if it goes through the pathway. They may need to make it easier access for everybody, access in the sense of, intravenous infusion normally is a little bit more complicated. Some places can do it. Having something, subcutaneous or something that we can easily administer to patients will be a break, but the results were very, very good.
Yeah, it's promising, and it's been out there for a while. I think it has clearly shown efficacy. And I think the paradigm shift with non-IVT treatments has to be that you may still need injection in some patients, right? It's not like we're going to have a cure for all, but the data from this trial actually shows some promising stuff. One thing I really liked from Michael Singer's talk was the perfusion. There was some improvement in perfusion, which was tying up to actually mechanism of action. And as you said, we're letting RVO heal by itself, and sometimes it never heals. Or in most of the time, it never heals unless you are young. And in this case, I think it's pretty promising. So hopefully they can do another phase 2 or later stage study to move this forward. One thing I wanted to talk to you about, to see what you think in terms of, a new mechanism of action. This is the data I presented in the first time data section, is PR001, which is, an endothelin receptor antagonist. So what happens is endothelin 1 is elevated in DR, in glaucoma, in other diseases, and by blocking the receptor, we are able, with this drug, we are able to actually, get vessels back to normal and get rid of ischemia and perfusion. So basically you're vasodilating instead of vasoconstricting, and you're able to get rid of ischemia. And this is actually an implant in PLGA formation given every 6 months. And so the thing that's very intriguing for me is that this was actually studied in glaucoma already, and the data was presented at ARVO this year, where we actually saw improvement in blood flow to the optic nerve and improvement in retinal nerve fiber layer, which we have never seen, and improvement in peripheral visual field.
Yeah. Yeah.
So when we look at this, we're like, okay, maybe it's real, maybe it's not. So there's a diabetic retinopathy study that was done, and that's the result I presented, where the low dose and high dose PR001 was studied against an observation control in patients with moderate to severe NPDR 47 to 53. And primary endpoint was obviously safety, because it's the first study in DR, and it was safe. But when you look at the exploratory endpoints, you actually saw improvement in function. You actually saw improvement in contrast sensitivity, low luminance visual acuity, and peripheral vision, compared to everything getting worse in the control or not changing. And then when you look at structure, there was improvement in microaneurysm, ischemia, and leakage. So it's very promising that we are going away from just treating the symptoms, as you said about RVO, to actually trying to attack the cause of the disease. So just wanted to get your thoughts on that.
It's great that we're having more and more completely new, completely different mechanism of actions. I think of the Wnt pathway as well, that is being explored by several companies now. These new treatment that you just mentioned may not only transpire for diabetic or any other vascular condition, but also for glaucoma, and easy to administer by means of an implant that dissolves in 6 months. So having new mechanism of action is going to open so many pathways to success, which means, giving something better to our patients.
No, I agree. I totally agree with you. Other talk I wanted to mention was by Giulio Bartoselli about putting Dutafab in the port delivery platform. So currently we have approval with ranibizumab, but this is Ifevencevic, which is a VEGF-A and Ang-2 Dutafab with no FC portion, so you can pack a lot of drug. What are your thoughts on that?
Well, basically, to use it within the PDP, that's the new name they use for the PDS. They call it a platform, which is a platform. You can put different drugs inside, and you can modulate, and you can, use a new agent like Ifevencevic. This new agent, being small, it's about 50 kilodaltons, similar to ranibizumab. Being a Fab, is smaller, and you can fit it there, and it can get into the eye through the implant. That's going to change the way patients are treated, I think, dramatically. We have several patients being treated. We're being part of one of the studies looking into the treatment frequency, and I'm amazed on how well the patients tolerate and are happy with the idea of having an implant. We are refilling them every 6 months or every 9 months, but having better drugs, ranibizumab is a great drug, but it's a drug that's been around for almost 20 years now. Having a Dutafab, something that can block VEGF and block Ang-2 at the same time, it's going to, raise the bar even more. So by means of an implant, we can have hopefully yearly durability and a massive response, raise the bar from the point of view of the response. We have to remember that by blocking the Ang2, we're not only attacking neovascularization and leakage, but basically what we're doing is we're tackling fibrosis and inflammation as well, because that's blocked by the pathway. So having DutaFab inside of a PDP, that's going to be a great thing for the future.
Yeah, absolutely. And, we in the U.S. have extensive experience with the port delivery system. Like you have the ex-US trials going on with port delivery system with ranibizumab. And I think the platform is great because now we can put second generation drugs. We can put, drugs for geographic atrophy. So very, very exciting times. Okay. An important session was gene therapies. I mean, who knew that we were going to have 3 different phase 3 programs looking at gene therapy? I don't think anybody 5 years ago could have expected that. So we have...
all of them very successful. All of them
yes,
very successful.
They have great data from phase 1, phase 2, and now they're all in phase 3. So we have Exovac in phase 3 program. We have 4D-150 in phase 3 programs. These are both intravitreal gene therapy for retinal diseases. And then we have the longer standing program that's been in phase 3 for a while, ABBV-RGX-314, which is a subretinal delivery in the atmosphere in a sense study. And then it's also being evaluated suprachoroidally for diabetic retinopathy as well as neovascular AMD. So let's just dive into gene therapy as a field first and see, because I think for the audience, this is not gene replacement therapy. This is biofactory approach where you get a certain gene for a drug. For Exovac and 4D-150 is a transgene for aflibercept, and for ABBV-RGX-314 is a transgene for ranibizumab. But what are your thoughts on gene therapy? Where do you see it fitting in the treatment of retinal vascular diseases?
Well, the original promise of the idea of having gene therapy was you get one injection, you get your biofactory inside the eye, started by this transfection of the virus that will put some genetic material inside, and that those cells are going to start producing whatever medication you need inside the eye. And the idea was that was once and for all, one injection, and then you're cured for good. And that sounded very promising. There were a bit of a drawbacks in the early beginning, some inflammation, the doses were tuned down a little bit, and now we have massive reductions in the amount of injections needed from these patients from the moment of treatment onwards, with a very, very good safety profile, which is what we want for every single treatment. We have seen treatments in the past that the moment you see infrequent but quite severe inflammation, for example, or any complication, adverse event inside the eye, people tend to walk away from there. So we need to walk carefully here. It's very promising. The results are being extremely good, very, very safe. So the idea of using a biofactory is going to be a very good option for many patients.
No, I agree with you. I think we have to think a little bit differently. As you said, for gene therapy, it's not a gene replacement, so it's not one and done in that sense. It's a gene therapy being used as a drug delivery platform. So we know we have a very heterogeneous patient population. Some are very, very high need, but that subset is 10 to 15%. Most of them can go 6, 8, or even longer weeks with the new agents. So I think we don't expect cure, as you said, for all the patients, but 50% or so far in all the trials. One thing I like about the gene therapy data to date is that it's very consistent in different programs. You're getting about 50% injection-free completely. We're getting significant reduction in treatment burden, anywhere from 75 to 90%. But I think the data, when we look at it, we have to look at what patients were studied, because the data looks better as you go from high-need patients to lower need patients. So gene therapy, very exciting. In the next few years, we'll have data to kind of look at, and we'll see where it fits in.
And we have several delivery options. I mean, some are designed to be used intravitreally. Some of them would need a surgery, to be delivered subretinally, which is, if you get, a higher bar in result, it's worth going through that pace. And also the suprachoroidal pathway is being explored to deliver the treatment.
Yeah, absolutely. So 2 in clinic, 1 in the OR. So yeah, very, very, very exciting. Now, another paradigm shifting treatment could be tyrosine kinase inhibitors, TKIs, and we have 3 different programs, 2 in phase 3 stages, OTX-TKI, as well as vorolanib for neovascular AMD. So tell us a little bit about OTX-TKI. You had a great presentation. You kind of gave an overview of the data to date for neovascular AMD. Tell us a little bit about what it is, what's the data, and then also about vorolanib.
Yeah, I presented the phase 1 data that came from the early OTX-TKI studies that were done, phase 1, one in Australia, looking for a biologic signal. They used it in treatment-naive patients, which is very interesting. We have to remember that this is axitinib, which is the most potent of the TKIs. TKIs work intracellularly by blocking any activity of the receptors intracellularly, regardless of what happens with VEGF on the outside of the cell. By blocking this, you inhibit all this cascade of events that leads to leakage and neovascularization. The first study, we mentioned also the preclinical study that we can pick up the signal of biological activity at 7 days. So very early onset, we can see the effect of the treatment. In the phase 1, we've seen some examples that in the phase 1 in Australia, treatment-naive patients with great response on wet AMD that did not need any further treatment for the next 12 months. Then we looked at the data from the phase 1 that was conducted here in the US. Basically, from the moment the patients received the implant inside the eye of OTX-TKI, the number of injections, they remained injection rescue-free up to 6 months. So 100% of patients for 6 months did not need any rescue treatment. And then onwards, if you include all the rescues, those done per protocol, and all the rescues that were done because the investigator feel that needed to be rescue the patient, you can achieve about 60% by 1 year. So that's a lot by means of just putting an implant inside the eye. We're doing the phase 3 study, SOL-1 and SOL-R, actually called SOL and SOL-R, and it's so easy to deliver. The injection is as simple as any intravitreal injection. So, and if we can manage to get something between 8, 9, 10 months, that should be more or less the sweet spot. It's going to be maybe shorter for some, maybe longer for other population. But if we can get that into the clinic, that's going to change dramatically the way we treat the patients.
So that was a great overview, Patricio, of the OTX-TKI. And as you mentioned, the SOL and SOL-R studies are ongoing. We expect some data next year from one of the studies. It's going to be really exciting to see how OTX-TKI can help our patients with neovascular AMD. Let's talk a little bit about the next program that's in phase 3 stage, is with vorolanib or EYP-1901. And there was a presentation by AbbVie on Davio 2 and of course their phase 3 trial design. Can you give us some updates on that?
Yeah, it's great to see that you have a new mechanism of action and you have several companies going through that path. So that means, this is a good solid signal that is coming up. The results of the Davio 2 study, which was done in patients with wet AMD, comparable to the one that I've just mentioned, these had the patients, 63% of them that were supplement injection free up to month 8. And that leads to an 85 to 89% reduction in the treatment burden at month 8. This is achieving stable vision and stable CST. So looking forward to, getting to the phase 3 study, doing the Lucia study. We're going to be starting soon in Argentina as well.
Yeah, and Lugano, that I participate, is already fully recruited. So again, from this program, we'll be expecting data next year, next year is going to be huge in terms of data for sure. Before we close, Patricio, let's talk about another exciting development that can impact our space. It's not a development in retina, but it has implication in retina, and it's a new class of molecules called sector. So this is Privosegtor. It's a neuroprotective agent that was studied in the phase 2 acuity study for optic neuritis, and what we saw was actually preservation of retinal ganglion cells and RNFL. So what are your thoughts on preserving axons and retinal ganglion cells in diseases like diabetic retinopathy and in geographic atrophy? What do you think about the data to date? Of course, I presented it, so you're not going to say anything bad, but
No.
but feel free to share your honest opinion like you always do.
Having Privosegtor, the OCS-05, it's going to be a big change because for example, optic neuritis, this is a condition in which we have no treatments available. I mean, we use the good and old steroids that we use for many conditions. When we have nothing else, we put the steroids. We need to replace that with a more targeted, more dedicated, and Privosegtor, it's going to be really interesting. You know, we can link it to the things that I mentioned at the very beginning. One of the works that I did when I was in London, it was working with the Institute of Neurology, and we published one of the first papers looking into optic neuritis and see the changes on RNFL. This was done with Stratos OCT, an OCT that's sort of pixelated like Minecraft. So we were doing that work looking at the changes in the RNFL in the patients and with optic neuritis and some of them MS, unfortunately. But it's amazing to see years later going back to that literature and saying we're going to be able to treat and reduce. The results that were presented is there's a reduction in the amount of loss that you have after an acute optic neuritis. Okay, so we can have neuroprotection inside the eye, as you mentioned, for any of the other conditions. That's going to be fantastic. The signal from that study was really, really interesting and above what it was expected. So looking forward to see the phase 3 studies and see what happens.
No, I totally agree with you. And there was a delta of 3 lines of difference between patients treated with steroid plus Privosegtor versus steroid plus placebo. And of course, this was IV treatment. So yeah, it's amazing that we have been after neuroprotection for decades, and we actually have first time we are preserving axons and retinal ganglion cells, and I think could be very exciting for diseases like diabetic retinopathy and geographic atrophy. So that's enough data dump from CTS 2025.
We're going to have a lot more next year for sure, as you mentioned.
Yes. So now let's talk about some other things. In the last few minutes, I usually ask colleagues that join me a few questions. So of course, you do a lot of work in clinical trials. You travel around the world. Everybody in the world knows you. Tell me, what are you most proud of as a career achievement?
Well, number one, being a program committee of CTS, let me tell you that.
That's nice. He always says good things. That's why he keeps moving up.
For sure. No. It was. I mean, this is for me one of the greatest meetings and most expected meetings during the year. This is the one to, go whatever other meeting or other things you have, go to this meeting. So that's a true statement. And maybe the other thing I may be proud of is, we managed to put Argentina on the map of clinical research, making sure coming here, talking to sponsors, saying we can do it. The conditions are different. In the US, everything is easy. So you have to have a sponsor that is happy to go through some hurdles, but it's going to pay back because you're going to get more patients, you're going to get diversity in the type of patient. We recruit really well. We managed to get at the top of the list of the top recruiters, many sites in Argentina. So that's something I'm quite proud of.
No, I mean, I think not to take that lightly. What that means is that you are putting a country on the clinical research map, and we are able to test these drugs in a very different patient population. So I know you have really been a leader, not just in Argentina, but also all Latin America. And I know you have helped so many people start clinical trials in Argentina and beyond Argentina. So thank you for what you have done for our field and for our patients. So that's great. Another question I always ask, you're too young right now, but what is your legacy? How do you want to be remembered as you retire? Like, I will tell you what I'll remember you as, but you tell me first.
I mean, I think it's very important to leave a legacy behind, people that go through successful careers and leave nothing behind. It's something to criticize, If nothing grows under you, maybe it is too big of a tree and doesn't allow things to grow back. We make sure we train fellows, we get new people, colleagues that have never been into clinical research, as you mentioned before, helping them start a new site, getting into something that they have never done before. Some of them older than me, and they, thinking they are towards the end of their career. So I think my legacy is going to be having, helped many other people get into this fascinating world of creating new treatments for the better of our patients, basically, which is what we work for.
No, it's great. So, I mean, you have, as I said, you have helped so many people, and one person can make an impact, so much impact. But if you train more people and expand your expertise, you can impact millions. So I think that's how I see you. On top of that, I see you as a family man, spending a lot of time with the family, asking the right questions, always being honest, and you always submit one of the best videos for CTS. So that's something to remember you with. So really a pleasure, Patricio, for being here all the way from Argentina.
My pleasure.
To Las Vegas for clinical trials at the summit, and the meeting was successful. Thank you for all your contribution and being here, and for excellent discussions about the latest development in retina. And I want to thank our audience for listening in. To earn CME credit, visit medittalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Have a question for our experts? Send it to us at cme@vindigocme.com, and it may be featured in a future episode. Stay tuned for future episodes in the Retina Radar series to keep up with the latest insights and expert discussions.